It is your third day during your internship. It is 9 a.m. in the morning and you just showed up to work. Your senior calls you and gives you an admission, and it goes like this. A 70-year-old male with a past medical history of hypertension, diabetes mellitus, coronary artery disease, status post 2 stents, was brought in by EMS after being found by the daughter to have slurred speech and drooping of his face. The patient was last seen to be normal at 6 a.m. Patient is brought to the ED, stroke code was called, and the patient is given to you. The current time is 9 a.m. Alright guys, so based on the history that is presented to you, patient has got hypertension, coronary artery disease, diabetes, and now he's coming with slurred speech and a facial droop. What does this tell you? Clearly everybody knows it, this is stroke. Alright, so once you know it is a stroke, what is the most important thing that determines what the outcome of the patient is going to be? It is time, my friends. Time changes everything. So time is the most essential part of this case. So this patient was last seen to be normal at 6 a.m. and now the patient is here and the time is 9 a.m. So how much time has gone by from 6 to 9? 3 hours. So let's begin this case and let's move on to the physical examination. Alright, so now let's move on to the physical examination. As I said before, physical examination is one of the most crucial part, and again, this is a stroke patient. So physical exam becomes even more crucial. So let's look at this patient's vital signs. He's got a blood pressure of 170 over 100, heart rate of 76, respiratory rate of 16, and a temperature of 98 degrees Fahrenheit. General, the guy does not look like he's in acute distress. He looks normal to you. Fine. When you go for a neurologic exam, you see that the patient's got a left-sided facial droop which is complete, which is affecting both the above the eyebrows as well as below, and the patient's also got a right upper limb and lower limb loss of muscle power. So he's got loss of muscle power in the right upper and right lower limb, but he's got an increased tone and increased reflexes. Alright, and cardiovascular exam is normal, respiratory system is normal, all other things are normal, but the important thing I want you to focus on is the neurologic exam. Now, with regards to where the lesion is in the brain and whatnot, I'll be talking about that in my next section, which is going to be on localization of stroke lesions. However, in this case, when a patient is presented to you, has neurologic deficit, does it matter where the stroke is? No, it doesn't. It matters is time. Time is all that matters for you at this point of time, right? So what are you going to do next? That's the most important question. Alright, so you have your patient here in front of you with a suspected stroke. What are the 3 most important tests that you must do on a patient who's having a suspected stroke? Number 1 is going to be an imaging study. You want to get a CT head or an MRI of the head because you want to make sure there is no bleeding going on in the patient's brain. Because the treatment for an ischemic stroke is in fact, yes, you can give them thrombolytics, you can do thrombectomy, you can give them blood thinners. You see how if you have not done a CT head or an MRI of the head and not ruled out an early bleed, you might actually cause worsening of the symptoms and cause the death of the patient. So anybody who presents with a suspected stroke, you must always get a CT head or an MRI of the brain. Either one of the tests would work. Question is which one you could get faster. Number 2 and 3 are basic tests, but you must get them initially. The reason is because of, if you look at the basic test that I'm talking about, is a finger stick, a POCT glucose level, and number 3 is going to be your oxygen saturation. The reason is if a person is presenting to you with symptoms of a stroke, but then again, if the patient was actually hypoglycemic, a finger stick of 30 or 40, he could have neurological deficit. But again, if you give D50, the symptoms are going to go away. It is not a stroke, but rather just a presentation of hypoglycemia. Then again, if somebody was hypoxic for whatever reason, that could also present like a stroke, but it is not actually a stroke. So these 2 tests must be done concurrently with your imaging study, which is CT head or MRI of the brain. So done with your 3 initial orders that need to be placed. Now let's move on to the remaining orders. So you're going to start off with the basic lab book that you would do pretty much with any case, which is going to be your CBC. You're going to get a CMP. PT, PTT and INR is very crucial in a patient with stroke because sometimes you give them treatment such as with thrombolytics. When you give thrombolytics, all of these things could get altered. So if you look at the inclusion and exclusion criteria to actually giving somebody TPA, these parameters are actually looked at, and therefore you need to get a baseline coagulation profile. You need to also get a lipid panel on these patients. Next, you also need to get an EKG because again, as you already know, some of the reasons why somebody can get a cardioembolic stroke is in fact atrial fibrillation. So if somebody has any abnormal rhythm, you're going to pick it up on your EKG. You also want to get a baseline chest x-ray on these patients. Alright, now moving on to this side, which I put in purple, is more important test that you must get a patient on with stroke as opposed to with any other patient. So as you see here, it is a CT angio of head and neck. Now important thing for you to remember is CT angio, you will give them IV contrast. And remember, contrast can cause damage to the kidney. So if somebody's got a kidney function which is not so great, you might not want to do this test, which is a CT angio. However, is there an alternative test that we could do? Yes, there is, which is MRA of the head and neck. Now, MRA of the head and neck, you do not use contrast. It is a non-contrast study. So if somebody's got kidney dysfunction, this becomes a very good choice for you to actually do the test. However, if somebody has any form of metals or some pacemakers, nowadays the pacemakers are compatible with MRI machines. Also, most of the prosthesis that's being used is compatible with MRI machines. Nevertheless, you need to make sure that patients do not have a metal which was placed in the 1980s or 1970s. So for that reason, if your patient has any form of metal or pacemaker, at that point, you would prefer to use the CT angio of the head and neck, especially if the patient does not have an abnormal kidney function. So these two tests are very crucial, and the reason why you're doing this is to essentially look at the blood vessels that supply your brain. And now recently treatment has changed to a point where if you actually have a large vessel stroke such as ACA, MCA, PCA, you can actually do a mechanical thrombectomy. The only way you can find out if there's a large vessel occlusion is if in fact you do a CT angiography or an MR angiography. Very good. Alright, next you're going to also do an echo with bubble study. Now an echo with bubble study is pretty much done only when you have a patient with stroke. Alright, and the whole purpose of doing a bubble study is basically seeing if there's bubbles that's going from your right side to the left side. Alright, so you inject some bubbles and you see it going from the right side to the left side of the heart, which essentially means the patient has either an AST or a PFO, basically telling you the patient may have had a paradoxical emboli. Alright, and then carotid duplex. Now carotid duplex was greatly done back in the day. However, if you're doing a CT angio of head and neck or an MR angio of head and neck, then your carotid duplex becomes useless. You don't have to do this test if you do either one of these two. Lastly, the Holter monitor. If your patient at baseline when you got an EKG did not show some abnormal rhythm such as atrial fibrillation, you're still in doubt. You don't know if the patient has got an abnormal rhythm or not. In these patients, what you should do is put them on a 24-hour Holter monitor so you can pick up some form of abnormal rhythm over the 24-hour period. And for instance, if you don't find on that, maybe they can go home on a loop recorder which can monitor the patient's heart rhythm for at least a month or two or even more. Now let's move to the most fun part, which is going to be your assessment and plan. This is the part where you're going to show your senior residents as well as your attendings that you know what you're talking about. You had a patient who came in with a suspected stroke, and as before, if you can recall, the patient's been here within 3-hour period. So now the goal is, back in the day we did not have treatment for strokes, right? You only could prevent the next stroke from happening, but now things have changed. Now you have treatment. You can actually bust open the clot and now the reperfuse the brain and the person is back to baseline, or have mild deficit but is going to improve. Or you could do a mechanical thrombectomy. So this is the era we are living in. So question is, how would you determine if the patient is going to get TPA or not? It's very straightforward, okay? Number one, what you need to know is the timeline. Within 3 hours, if the patient presents to you in less than 3 hours, then you can give them TPA if the patient has certain inclusion and exclusion criteria. So this is the table that you guys have to look up, and this table, I'm not going to explain every little part of this table because it's self-explanatory. You will go through this table and you will see if the patient meets criteria for TPA or not. If you scroll down all the way to the bottom, you'll see there's additional criteria, additional exclusion criteria to tell you if you could give a patient TPA even between 3 to 4.5 hours. So bottom line is, until less than 4.5 hours, you could still give a patient TPA. So now let's talk a little bit about TPA because it's so crucial that you should know certain things about TPA. Now when you give a person TPA, which is your gold standard of management, if the patient actually falls within timeline of less than 3 hours or less than 4.5 hours, you will give them TPA. There's important blood pressure parameters that you must know when you're giving a person TPA, and that is if the person's blood pressure is 180, if it's greater than 180 over 110, they say you should not give them TPA because there's an increased risk of bleeding in the brain with such high blood pressures, right? So what you should do in these patients is, again, would you want to let it go and say, you know what, guy's blood pressure is elevated, so let's not give him TPA? That doesn't make any sense because it's a life-saving procedure. He falls well within timeline. The only thing stopping you is something that you could medically manage. So start the patient on blood pressure medication and bring the blood pressure down and still give the guy his TPA. Alright? So what medication can you use? There's 3 of them which you must know. Number 1 is labetalol. Number 2 is nicardipine. And number 3 is clevidipine, which is also a calcium channel blocker. The interesting thing about these 3 medications are that you can give them as IV boluses and then continue a drip. So you can titrate and kind of really monitor what the blood pressure is going to be. Now you don't want to drop the blood pressure too much either. You want to maintain the blood pressure somewhere around 180 over 105. Around this region is perfectly fine. Alright, now again, one more thing, if you look at when somebody is administering TPA, they do very frequent blood checks during as well as after giving the person TPA. Now, when you give TPA as all medication, you know that there could be some amount of allergic reactions. And one of them that actually happens is in fact angioedema. When you have angioedema, you'll always treat them with the same way you'll treat angioedema, such as antihistamines as well as Solumedrol. However, you should never ever give these patients epinephrine. You know why? Because what is epinephrine going to do to your blood pressure? You just gave that guy TPA and now you give them epinephrine to overcome this allergic reaction. Poof! You're going to cause excessive bleeding in the brain, which is going to worsen everything. So remember that this could be a board question as well. So now you're done with your first part, which is going to be your TPA. You gave your TPA and the patient is doing better. However, the big question comes is, okay, are you going to do a mechanical thrombectomy? Everybody speaks about this. The question is, this is where you're going to do your next 2 tests. Remember, I told you to do a CT head here or an MRI of the head to make sure there was no bleeding so you could give that patient TPA. Now, the next test I told you to order was in fact a CT angio or an MR angiogram so you could see if there's a large vessel occlusion or not. And if there was a large vessel occlusion, then you could do mechanical thrombectomy. Can they get it even after receiving TPA? Absolutely yes. Absolutely yes. So what is the time cutoff for this procedure? Now, the time cutoff for a mechanical thrombectomy is up to 24 hours from the last time the patient was seen to be normal. So until 24 hours you could do a mechanical thrombectomy. If I change the case a little bit and told you the same patient who was last seen to be normal at 6 a.m. presented at 12, he clearly has passed the cutoff for TPA, right? Because the last cutoff was 4.5 hours. However, if you did a CTA and an MRA and you saw the patient has a large vessel occlusion, can you do a mechanical thrombectomy? Absolutely yes. My point is mechanical thrombectomy goes with or without TPA. That's my point. And your time cutoff is going to be for 24 hours. And when I say large vessel stroke, it's both anterior circulation and posterior circulation, which is going to be inclusive of what? It's going to be your anterior cerebral artery, middle cerebral artery, posterior cerebral artery. You could do it for your basilar artery, and it could also be for your vertebral artery. So any large vessel stroke, if the patient is within 24 hours, you could do a mechanical thrombectomy. Again, you should look through the inclusion and exclusion criteria for these procedures as well. However, important thing is that you could still do it. Alright, so your patient came within time, you gave the patient TPA because the CT head and MRI did not show a bleed. You got a CT angio and an MRA and we showed a large vessel occlusion maybe. Now the patient is going to get a mechanical thrombectomy. Now comes the big question. Where is this patient headed to next? Is the patient going to the floor or is the patient going to go to ICU? That's the big question. This patient just had a neuro intervention with TPA as well as mechanical thrombectomy. So clearly this guy is going to go to the ICU. Before we go on to the MICU management, I just want you guys to really recall something and really remember something important. The thing is this, by the time the patient comes to you as an intern, all this workup, the patient would have already had a CT head. He would have already been given TPA. He would have already had his mechanical thrombectomy, and you will only get the patient after. The reason I wanted to go over all this is do not ever take everything blindly. Always ask questions and learn, and therefore I want you to know what's going on even before the patient came to you. That way you're not having any gaps in your real learning experience. Okay? Alright, so now you have your patients in a MICU. This is a patient who received TPA and had a mechanical thrombectomy, and he's down here in the ICU, and you're the doctor who's taking care of him. Important things that you must monitor. Number one, blood pressure. When a person has received TPA or mechanical thrombectomy, at what blood pressure would you start the patient on a blood pressure medication? That's a very important question. The blood pressure target in a patient who has received this procedure is in fact going to be 180/105. This is your blood pressure. The idea is you want to still have some component of permissive hypertension, however not too high, but this is your mark, 180/105. You'll see a patient who comes in who doesn't get this procedure done at all. His blood pressure goal is much higher. Reason is there's much higher chance of bleeding in a person who's had TPA as opposed to a person who did not have TPA. So blood pressure target is 180/105. You will only start them on medication if the blood pressure crosses this level. Alright, so that's important. Number two, fluids. Important thing is if somebody comes with a stroke and you say, alright, this patient probably has dysphagia, so I cannot start this guy on a diet, and then you look at the patient's lab and you're like, alright, the patient's got hypernatremia, maybe sodium is 155, and the senior resident asks you, okay, what fluid do you want to start this patient? You're like, okay, let me give the guy a little sugar, maybe D5. Since the sodium is high, let me do half NS, D5 half NS. You think this is a great combination? It makes pretty good sense to start the patient on D5 half NS, but you are going to kill this patient by giving this fluid. Never ever do any form of hypotonic solution to a patient with stroke, period. That's it. For the first 24 hours, do not use anything other than isotonic fluid. I don't care how high the blood pressure is. I don't care if the patient is fasting, his NPO. You will start the patient only on normal saline, nothing else. It should only be isotonic fluid. Alright? So normal saline is the only thing you'll do. Alright, so you got your blood pressure target, you got your fluids. Next, head of bed. Head of bed elevation, there's two schools of thought. Let me put it this way. If you look at a patient, think about it. If the person is lying down flat, is gravity going to force more blood to go to the brain? It is, right? It makes sense. So one school of thought always said, if the patient was lying down flat, then there's increased blood flow to the brain, it was actually good. However, another school of thought says the patient has dysphagia. Most people who have strokes will end up having some form of dysphagia, maybe due to the effect of the 9th and the 10th cranial nerve, which is involved in the gag reflex. However, so what they say is you want to place the patient at a 30-degree angle because now you're going to prevent the patient from aspiration risk. However, there's both schools of thought, but for all practical purposes, what you're going to choose is in fact 30-degree elevation of the bed. That makes perfect sense. It works, and it's totally fine for you to go ahead with 30-degree elevation of the bed. Fine. Number 4, temperature. Is fever good in a person who's had a stroke? Absolutely not. Fever is terrible. Hypo and hypothermia is bad, but you want to prevent the person from having fever. If the patient has a fever, you would possibly see the reason why the patient is having a fever. Maybe it's an infection, maybe it's medication related. However, you want to maintain this patient as normothermic as possible. Alright, normothermic as possible. Give him Tylenol, give him whatever he needs to do, but we want to maintain him normothermic. What about feeding? Now feeding is another important question. Again, as I said, patients with stroke can have a certain component of dysphagia, so you must get an official speech and swallow evaluation before you start the patient on a diet, because the next thing you don't want to cause this patient is aspiration, pneumonia, and cause the patient to become intubated and have a very bad course in the ICU. So never start the patient on feeding until you get a official speech and swallow evaluation. Another one you have to talk about is sugars. Now the patient, you want to make sure the patient is not severely hyperglycemic, nor is the patient severely hypoglycemic. All right, so make sure you maintain the patient's sugars. You're checking the patient's finger sticks frequently. However, do not start the patient on D5 or D5 half NS, nothing. You should not give it sugar via IV access. If you really need to treat the patient, then you can put an NG tube in and you can start the patient on feeding until officially cleared by speech and swallow. But always remember, maintain your head end of the bed at 30 degrees. All right, another important question becomes number 0.7 is your DVT prophylaxis. DVT prophylaxis. Alright, so as you know, probably in the hospital already, there's oftentimes you have three possible options when it comes to DVT prophylaxis. Number one is Lovenox, number two is heparin, third one, if there's contraindication to the first two, or for whatever reason you don't want to do the first two, you will put them on a Venodyne boot. Now this patient just received TPA. Would you want to give this patient any form of Lovenox or heparin? Absolutely not. Let me tell you a real truth. For the first 24 hours, okay, after patient received TPA, the patient should not have any arterial stick. So no to arterial stick, no arterial stick, no anticoagulation, no antiplatelets for the first 24 hours. Do not give this patient any form of Lovenox or any form of heparin. Only thing you'll do is Venodyne boots. All right. It's basically you'll be attached to a calf, and that basically causes vibration. Now with regards to Venodyne boots, there's two important understanding. Number one, it prevents stagnation of blood, pushes the blood up, and this prevents stasis and prevents the formation of clot. But it also has a thrombolytic effect. There's a certain articles that's out there, if you read, it actually has a thrombolytic effect. So what you're going to do is, for DVT prophylaxis for the first 24 hours is in fact going to be only Venodyne boots. Now you know how to manage your patient in the MICU, especially pertaining to all the different entities that you should know as an intern. However, let's not forget the other medications that the patient also must be. Fine, you gave TPA and did a thrombectomy, all and well. However, there's another medication you must give a patient who's having an acute stroke, which is in fact called the statin, right? The statin, atorvastatin, rosuvastatin. You want to use a high intensity statin, atorvastatin or rosuvastatin. Either way, you're going to start the patient. For instance, if I say atorvastatin, which is very commonly used, you would use 80 milligrams at bedtime for 4 days, and after 4 days you can drop the dosing down to 40 milligrams at bedtime. All right, but either way, you're going to start the patient on a statin at the time of diagnosis for a acute ischemic stroke. All right, now apart from that, fine, you have your patient in the ICU, you're managing all these parameters as I already explained. And what else do you need to do? You need to do something very important, because this patient just received TPA or mechanical thrombectomy. The problem with these two maneuvers or these two interventions is that there is a risk of bleeding on top of it, which is known as the hemorrhagic conversion. That's the reason the patient is in the ICU. So when the patient is in the MICU, you need to do frequent neuro checks. All right, frequent neuro checks. Now if for instance you are checking the patient's frequent neuro checks and you find out that the patient's one eye pupil is blown out, looks larger than the left side, then you are thinking of a possible hemorrhagic conversion. Or for instance, the patient has got a new neurologic deficit. Whatever happens, some form or any form of neurologic change, you must do a re-imaging of the brain. It could be a CT head or it could be an MRI. It must be done. If there is a change in the neurologic status, you must do a re-imaging study. It's very important. If your neurological status remains intact, there is no change, everything is going very smooth, at that point you could repeat imaging study 24 hours after you gave the patient TPA. Okay, 24 hours post TPA, you could do a re-imaging study. Once you finish your re-imaging study, and if all is well, the patient is improved, the next day has come along, the patient was evaluated by speech and swallow, he or she is eating beautifully and everything is going well, blood pressure is fine. At this point, you can actually downgrade or transfer this patient from the ICU to the floor, to the regular medical floor, where the patient can have the rest of the complete workup of the stroke, and then the patient can go home. Maybe the patient might have to go to rehabilitation or whatnot. The rest of the workup is in fact going to be an echo with bubble study. Now when you do an echo with bubble study, you're seeing to see if the patient has some form of AST or PF4, basically saying there is a hole between the septum in your atria, right? Now the reason is, if the patient has a DVT in the leg, normally if you follow the normal scheme of things, the clot should travel to the lungs, not to the brain. But if you have a hole in the heart here, it's going to shift onto from the right side to the left side and end up causing a stroke. So this is called a paradoxical emboli. For the longest time, there has been multiple discussions about whether you want to close a PF4 or keep it open. Until now, if there was a board question, you will say do not close it. However, there's been multiple studies that's actually pertaining to cryptogenic strokes, which means the patients are really young, they do not have any risk factors, they're coming with multiple recurrent strokes. In fact, multiple studies are suggesting to go ahead and close the PF4 or an AST. However, there's multiple criteria that need to be met for it. But the problem with closure is that when you close it, this device by itself is going to cause an abnormal heart rhythm. Guess what rhythm this is? Atrial fibrillation. Oh, wait a second. What does that predispose you to? It predisposes you to getting a stroke. So I don't want to get into a controversial subject. I just want to know that these are the upcoming things that's happening all around us. All right. So just keep that in the back of your mind. But get an echo with bubble study, get a Holter, and next big question, in the Holter you're going to see if the patient got atrial fibrillation or some form of abnormal rhythm, and you'll take care of it. Fine. Next question is aspirin. Now anybody who gets a stroke clearly needs to be an aspirin, but if a patient received TPA or a mechanical thrombectomy, question is when can you safely start the patient on aspirin? If you do a reimaging and the stroke is remaining stable, nothing is changing, at that point 24 hours later you can start the patient on aspirin. It's completely fine. And what about chemical DVD prophylaxis? Also 24 hours later, if everything is stable, you could restart your chemical DVD prophylaxis on this patient as well. Very good. Lastly, just to add on one important point, if a patient developed atrial fibrillation on your Holter or on the initial EKG, now you need to put this patient on anticoagulation, right? You need to put this patient on anticoagulation. Very important topic. Now, question is, when can you safely start this patient on anticoagulation for atrial fib? And remember, you have to follow your CHADS-VAS score, which will be covered in the next subject, which is going to be in cardiology. But follow CHADS-VAS score. So if a patient received TPA or mechanical thrombectomy, if it was a really large stroke, or if there was a hemorrhagic conversion, in those patients, ideally what we should do is wait to about 2 weeks before you can restart, or before you could start the patient on anticoagulation for atrial fibrillation. But if it was a small stroke and if there was no hemorrhagic conversion after you did a TPA or mechanical thrombectomy, these patients you can start after 48 hours. It's completely fine. Alright guys, so this concludes our section on strokes who receive TPA and mechanical thrombectomy. This covers everything you need to know as an intern to manage your patient. I hope you enjoyed this video, so please subscribe and leave any comments below, and I'll see you guys on the next video.